Hello, and thank you for joining us. I am Jasmine Navarez, Digital Content Coordinator here at Simulations Plus. I'll be hosting today's webinar, Behind the Scenes, making sure we don't have any technical difficulties. In this webinar, presenters Scott Siler, Zack Kenz, and Celeste Vallejo will discuss how QSP modeling can optimize obesity treatments and showcase Simulations Plus proprietary QSP modeling software fails to explain design rationale that guided development of the Obesity Sim model. President of our QSP Pittsburgh group, Steve Chang, will serve as our moderator today. A few housekeeping items before we begin. We take your privacy rights seriously. By registering for and attending this event or participating in the Q&A session, you are allowing us to contact you for follow-up. You may ask questions via the questions panel on your dashboard at any time. If you need assistance, please use the hand raise icon. We'll address all questions in the Q&A after the presentation. We'll also be launching a few polls during the presentation, so we encourage everyone to participate. And now I'll hand it over to our moderator, Steve Chang, to introduce our speakers.
Thank you, Jasmine. So the team that developed the model and will serve as your presenters today includes Scott Q. Siler, Zack Kenz, and Celeste Vallejo. And look forward to hearing the presentation by the team. Take it away, Scott.
All right. Thanks, Steve. Thanks, Jasmine. Welcome, everybody. We're really excited to share our new QSP model, OBESITYsym, with all of you. And it's been optimized to help simulate and support clinical development of obesity drugs. Before we proceed, let's see if I can get the slides advancing. There we go. Our disclaimer, really important that everybody reads it. If you want the notation version, it is the information provided here is educational, not intended to dictate the treatment of patients. All right, that gave you enough time to read it all, I think, right? Okay, so with this is sort of the upshot of OBESITYsym, its attributes, and then of course we'll dive into this in greater depth here subsequently. So at its core, really, we've developed OBESITYsym that provide the ability to support predictions of efficacy, weight loss, while at the same time, predictions of nausea, one of the primary potential adverse events. It's really kind of walking the line between the two that dictates the successfulness, the utility of a treatment for obesity here. And so we've included many of the key indicators, outputs that align with predictions of efficacy as well as nausea. We've set it all up properly to incorporate all of those aspects. We've also then optimized it utilizing the primary compounds that are available, primary drugs available to patients at the moment for obesity, semaglutide, liraglutide, and tirzepatide. Mind you, they're all GLP-1 receptor based. Of course, tirzepatide has the dual agonist feature as well, which is, again, why we're kind of having to walk that fine line of nausea versus efficacy, versus weight loss, versus reduced food intake. So in addition to being able to predict efficacy, to be able to predict nausea, of course, we can look at the potential for combinations of treatments with additional modalities, different targets, different approaches, even combinations of pharmacologic and behavioral, depending. And really, this is an expansion of some of our earlier work and other platforms as well, looking at weight loss. So we're pretty excited about this. Another really exciting aspect here is this is we're now utilizing for this effort our proprietary Simulations Plus QSP modeling software platform, which has itself some fantastic attributes, not the least of which is the optimization of the simulated populations, particularly in the context of the clinical data with and without treatments. So again, we'll dive more into this here subsequently. Let's see. So our agenda is give you a brief introduction to QSP modeling and Simulations Plus. Just because I think we have a pretty diverse audience here, a very brief overview of obesity's pathophysiology, some of the treatments and adverse events, that then cues us up to talk about how we've designed OBESITYsym to address each of those and be able to simulate most of those. And then we'll conclude with giving some information on how to access OBESITYsym, and then open the floor for questions on the kind of the final roughly 5 to 10 minutes. Okay, then before we get started, we're going to prompt you with a poll question. Jasmine?
Yep. So our first poll question is, are you excited about the public health impact of effective obesity medications? And then it's a simple yes or no. And I'll give everybody a couple seconds here. Okay, and I'll go ahead and end the poll there. So we're at 88% yes and 12% no. Back to you, Scott.
All right. There we go. Okay, I got to remove the poll prompt. There we go. Okay, so Simulations Plus. Let me, I think most everybody in this audience is familiar, but I think there are also some high notes because there have been some recent developments for us to add here. So we're a pretty sizable company. I think we've actually crested above 200 employees. We've been around for a while now, right? Over 25 years. And over that time, our footprint within pharma has grown, largely because our addition of numerous modeling modalities to the organization. So, of course, everyone's familiar with our PBPK success in that area, as well as cheminformatics. In the clinical pharmacology and pharmacometrics area, we have a well-established footprint there. We're growing our regulatory strategies group. And now within the quantitative systems pharmacology group, we're delighted to kind of alert everyone, if you weren't already aware, that our team has grown twofold over the last 12 months. And that is in large part because Steve Chang and the company that was formerly known as Immunetrics joined the Simulations Plus family. So we've been integrating our existing and our new QSP colleagues, and thus far, that integration has gone very smoothly, very well. And in fact, OBESITYsym is something of an example of the fruits of that labor. We're, again, quite excited by this. Another important point to note, sometimes it's probably implicit, but it's also useful to call this out, is within Simulations Plus, while they present as 5 separate streams, if you will, those modeling modalities, in reality, all of us are interacting with each other frequently. So whilst you're going to hear mostly about QSP modeling efforts, we've consulted with our PBPK and our cheminformatics and our CPP colleagues along the way as well, because there are certain aspects that they bring to the table, certain expertise that is as well useful to QSPers and vice versa. Let's see, so moving on. There we go. Before we dive in too much further, I've learned in my 25 plus years of QSP modeling that everybody seems to have their kind of own unique definition thereof. So I'd like to kind of put the cards on the table and make sure everybody's abiding by or understands how we're describing our work. So really at its core, quantitative systems pharmacology models include a mechanistic mathematical model of the underlying pathophysiology of the disease. That's to varying degrees of sophistication, of mechanistic representation, but no matter what, that is really at its core. And that allows us to understand the disease well, to develop simulated populations that include interpatient variability, and really get a sense of disease progression when that's in play as well. So then in order to understand and be able to predict the efficacy of drugs, of course, we need to overlay those drugs upon that mechanistic model. So the first step, of course, is the exposure of the drug, the pharmacokinetics. And as you all know, within Simulations Plus, we have some fantastic tools, some fantastic scientists capable of supporting exactly that endeavor. So we develop these PK models and bring them into the mechanistic model one way or another in order to provide the exposure of the compound at the site of the target. And then, of course, the final kind of step here is connecting the drug's effects, drug compound exposure to the drug's effects. Now, often we refer to that as pharmacodynamics, but in reality, perhaps just understanding how it's interacting with its receptor is one bit of information. What we really need to do is kind of complete the loop by determining how that target, the receptor in this example, is then interacting with the pathophysiology. So really, it's perhaps more of a mechanism of action. It's also important to note that we develop our models in a way that enables them to be expandable. So because new targets are discovered all the time, we're able to then modify, update the model, expand the model to incorporate that as we want. And then finally, it's really the intersection of all three of these that allow, especially when we consider a disease like obesity, to look at the balance between, again, efficacy and adverse events. Our team is fantastic. I always love saying that, and because it's true. And one of the reasons, one of the key attributes that makes it fantastic is that we have a real diverse background amongst the team. It's been my experience that QSP modeling, there's almost no individual that comes in with a full complement of all the skills that you see listed here on this slide. Over time, as you practice the art, you kind of gain many of these skills. You become somewhat accomplished, but really to have someone who is trained in and an expert in each of these areas allows us to then refer back and get that kind of expert counsel as we're developing our models, using our models. So, and you'll see as we're moving along, certainly, 3 of the members of our team, 4 of the members of our team, and I think you'll understand that it's the interaction between all of us that allows us to develop these models. We have been developing models for a very long time, really developed a methodology, along with others, of course, that is widely practiced throughout industry today. And this is a key point that is sometimes underemphasized, which is in addition to the models that we already have in our library, which is coming up in the next slide, we have the ability to make QSP models in new disease areas as well. And so if you foresee in your pipeline the utility of having access to such a model, I think you'll see that we are probably the best resource for that. Speaking of the models in the library, again, our selection, our library doubled in size over the last year. Really exciting. So we have immuno-oncology, autoimmune diseases, inflammatory and fibrotic diseases, of course, our safety QST offerings, and now in the area of metabolic diseases, we have obesity and OBESITYsym. Super excited about all of this. Over the years, deploying our QSP practice across the entirety of the organization, we've had a lot of highlights, a lot of key successes. And this slide, I think, describes many of them. And I think the 2 that I would like to call out is, in particular anyways, number 1, many of our simulations and our predictions have really supported internal key decisions across pharma pipelines, whether it's identifying a dose, whether it's supporting go-no decisions or retiring a program, some really important decisions that the more information you have, the more we can help with those simulations in addition to additional in-house information. And then the other, I think, key attribute success that we've had is we've really designed our practice such that we facilitate interactions with, communications with regulators. Vast amount of experience there. This is sort of a growing, emerging area, QSP modeling and interactions with regulators. By all accounts, the more experience an organization has doing that, the more likely that there will be success. There's also some kind of future, with an eye towards the future, some really nice developments that I'll kind of leave that statement there, but I want you to keep an eye forward because I think there may be some interesting announcements coming over the next couple of years. Okay, so there's your introduction to Simulations Plus and the QSP group. And so let's dive into the disease itself. Again, I'm going to focus on some basics first and kind of introduce everybody to the pathophysiology, treatments, adverse events, just acknowledging that we have a diverse audience here. So let's start with kind of the definition, the clinical definition. So the BMI of greater than 30 kilograms per meter squared. So that's essentially what body weight over the square of your height, right? It gives you a sense of where you stand on the kind of across a population in terms of body weight. Now, of course, it isn't a perfect predictor. You can have tons of muscle mass, you can have tons of adiposity, and your predisposition towards metabolic syndrome, et cetera, differs in those cases. But as a kind of a general category, a general measurement, it has been proven quite successful. Imperfect, but very useful. Nonetheless, this is the clinical definition, and it is really a consequence. It emerges as a result of there being positive energy balance. So this figure from the Tufel paper shows kind of the classic sort of description where if you have some sort of a energy intake exceeding expenditure, the propensity for weight gain increases and manifests. Along with that increased adiposity, then in that sort of positive calorie balance scenario, it really drives a number of associated maladies, and you'll see in a subsequent slide many of them listed. So really this is kind of an important area for us in also not only understanding how it's happening, but the prevalence, looking at it from a population point of view. So these data from the Fryer paper are focused on the US, and you can see since about 1980, just the slope of the increase in obesity in the US has dramatically increased. This trend that you see here is also observed worldwide across most countries. And so, again, we know that it's happening at this ever increasing rate. We know that it has these maladies with it. And so, it's really incumbent upon us to work towards, kind of dampening the fire. Now, that said, there's really, to me, obesity is the ultimate, perhaps, example of the intersection between genes and environment. So, kind of the classic scenario for everything, including obesity, is genetics really kind of define where you might sit, and within a specific range. In other words, it kind of predisposes individuals towards different steady state body weights. And there's been some really nice advancements in nice studies, nice tools. For instance, this fMRI data at the bottom from the Kenz study that really shows that at least phenotypically, there are indeed differences in the way individuals respond to certain cues, whether it's a low-fat milkshake, whether it's water. And so, again, coming into a specific environment, individuals will respond differently. That said, of course, the environment, if you will, can certainly kind of take over and push an individual towards that positive calorie balance, that weight gain. There's also, I think, another really important point here with the emergence of finally successful treatments for obesity. I think we've really learned that there are interpatient differences. Not everybody has responded the same to these fantastic drugs that are now available, because they come to it with different genetics, right? So it's also, from my point of view as kind of a nutritionist originally, you have to acknowledge that you can't apply the same expectations for results across the board to all individuals. I think that's an important thing to acknowledge as well. Okay, so pressing on, let's see, there we go. That said, weight loss in individuals who are overweight, who are obese, provides tremendous health benefits. So I really like the data here from this Kunti paper. This is actually looking at kind of nutritional lifestyle interventions and summarizing obviously the risk or the improvement of risk reduction that comes along with whether it's sleep apnea, type 2 diabetes, hypertension, dyslipidemia. There's a long list there. You can see that kind of almost in an exposure response way, the more weight loss you have, the more improvement you're going to see. This is, again, a fantastic set of data. We're also seeing with some follow-on studies and clinical studies with the existing drugs, similar sorts of observations. I believe that semaglutide, a clinical study with that just recently was terminated early because the improvement in chronic kidney disease was so obvious that they didn't need to conduct the full length of the study. So again, coming at it from multiple directions, arriving at the same result. This is a fantastic, fantastic not just for treating obesity, but for treating many things as well. And we're excited to support this going forward. Okay, before speaking of going forward, next up is a poll question.
All right. Our second poll question is, does your company have an obesity treatment in the pipeline? And there's options for yes, not yet, and not of interest. So we'll give everybody a couple seconds here. And I'll go ahead and end it there. We have a good batch of everything. There's yes in clinical trials, that's at 19%, but our highest is also not yet at 30%.
All right, thank you. Okay, let's resume our regularly scheduled broadcast. So this is, I think, an interesting, looking at where we are now, where we have tirzepatide, semaglutide, liraglutide available and effectively treating patients. You can see as we look backwards, it took us a long time to get here. Lots of, almost and not quite, and providing some benefit, but also in some cases, some risk, some maladies that came along with some of these treatments. So this is a kind of the revolution is upon us, I think, with respect to obesity medication. And, as we showed in the previous slide, as well, some positive downstream responses. So one of the commonalities of these new medications, effective medications, is that they are all deploying, to some extent, the same mechanism, the GLP-1 receptor agonist. Now, again, tirzepatide has a dual agonist. In addition to GLP-1, it also stimulates or is an agonist for the GIP receptor. So for each of these treatments, and kind of as we move top to bottom here, liraglutide was first to market, then semaglutide, and most recently tirzepatide for obesity. Also, it's important to note all three of these drugs initially arrived at the market to treat type 2 diabetes. And for the most part, when it comes to the obesity indication, the dosing is a bit higher. And so, you can see that the magnitude of weight loss and the time of weight loss shown here on these figures, and they're certainly very important to pay attention to each. But again, we're also balancing the propensity for nausea that comes along with activating that GLP-1 receptor. And so each one of these medications also employs a dose titration protocol. One of the interesting aspects of the nausea is that there seems to be some tolerance, and I'll show you some data on the next slide that includes that. So, kind of a small steps up in that up titration allows for that tolerance to establish and, patients to ultimately successfully utilize these medications over time. Another important aspect of these trials, important to us, at least as far as simulation goes, is that all patients are counseled on a lifestyle intervention. You can see that they're counseled to reduce their caloric intake by about 500 calories a day, as well as to implement an exercise program. And so, it should be clear to the eye that there is some appreciable weight loss in the placebo group as well. And of course, we have to take that into consideration in our simulations as well. Okay, then on to the next, which is the nausea incidence. And as I verbally referred to in the previous slide, there is certainly relatively high response rate for the incidence of nausea in these clinical trials. And so you can see that in the figure kind of summarizing the responses for tirzepatide, semaglutide, and liraglutide. Also, I think the figure on the bottom shows nicely that sort of adaptation that occurs, especially when you look at kind of the second half of this, So this is a temporal profile self-reporting of feeling nauseous. And once a patient is kind of acclimated to a given dose, you can see the reduction in nausea over time, right? Again, there's something of a tolerance that's established. And that is, a design consideration for us. It's also what allows these drugs to be effective and, have a relatively high retention in terms of patients staying on them. Now, clearly, there are also other GI adverse events that have been reported. We've focused on the nausea because it's, if nothing else, kind of the canary in the coal mine. By that, I mean the incidence is a bit higher. Many of the other AEs as well kind of follow in the same patients. And so we're tracking this first. You'll see shortly that we're focused on, at this point, only including nausea in OBESITYsym, but going forward, it's a high potential that we can expand the model to incorporate some of these other adverse events as warranted. Okay, so let's see, we're kind of zooming along, which is good. I want to make sure that Zach and Celeste have an opportunity to share some of the optimization results with you. I think I have a couple, 3 more slides just to describe some specific design considerations, and then I'll hand it over to them to show you the actual simulation results. So I mentioned before, we're using our proprietary in-house QSP modeling platform, Thales, in order to develop OBESITYsym. I'm really excited about this. A number of fantastic attributes. We found it to be really easy to kind of climb the learning curve. By that I mean, relies upon many of the same sort of concepts, coding approaches, etc., that other QSP modeling software also utilize. But some of the where it really separates itself is in, I would say, the population generation and simultaneously fitting. Those optimization capabilities really allow us to take several steps forward to perform, kind of the modeling, etc., even faster, even more accurate. And when you see the optimization and validation results, I think you'll agree as well. There are a number of other attributes. Those are the 2 that I'm calling out specifically. And, I think we've had some webinars in the past that have described this to greater extent, and likely to be more coming in the future as well. Also, within OBESITYsym, we've kind of, I think it's fair to say we're standing on the shoulders of greatness, if you will, those who came before us. So we're using this Hall 2010 QSP model of energy balance as sort of the foundation of OBESITYsym. Coincidentally, Kevin and I worked together. We kind of started our careers together at the same time, sitting side by side, working on metabolic diseases. And he's gone on to do great things, this model being an example thereof. So really what we did was we started with that, brought all those equations over, and you can see tracking, for instance, energy balance, or not just energy balance, but nutrient balance, whether it's glucose, fat, or protein, and as well as the energy expenditure, all of that included. Sometimes I describe this as perhaps the most famous of QSP models, not only because it's been cited so much on PubMed, but also in the popular press. What we did is we took that and we've extended it to include pharmacologic and nausea submodels that allow us to then address these various questions that I just described earlier with respect to how these treatments might affect both weight loss and nausea. Okay, so here is what I would describe as our summary diagram. It's something somewhat simplified version, but it does, I think, nicely describe the key components here of what's in OBESITYsym. So I like to start over kind of in the middle in the nodes that are in black, fat mass, body weight, lean body mass. So really that's the body composition. And that's kind of the consequence of what you see on the right, the energy expenditure and the 4 different areas that contribute to overall energy expenditure, as well as what's on the left, which is caloric intake and the 3 different macronutrients. There are some, we're keeping track of each of these explicitly because they have kind of unique and quantitatively distinct contributions to either food intake or energy expenditure. And it's also possible that there are certain drug targets that might favor one versus the other. So this enables us to then, as we move to the treatments area in kind of the yellowish color, pay attention to compound attributes, potency, PK, as well as the potential for desensitization or tolerance. And then we can now utilize all of the above to predict the influence on caloric intake or energy expenditure on the right-hand side, and as well as in the same QSP model, the generation of a signal eliciting nausea, as well as the generation of a tolerant signal, kind of offsetting the nausea signal. And we're able to then predict the incidence of nausea for a given dosing paradigm at the same time that we're predicting the weight loss and the effects on body composition. Let's see, we've optimized this, as I mentioned before. I'll state again, based on the clinical literature for semaglutide, liraglutide, and tirzepatide. We've also further validated with not only some of those subsets of data, but also some nutritional intervention studies. And then, of course, this enables us to make predictions of novel compounds with potentially novel treatments or targets, or even the similar targets, but different PK, different potency, all of the above. And therefore, we can utilize this to kind of ensure that the next wave of treatments is better than the current wave, right? To really help the clinical development programs. Okay, I think it's time for me to take a seat on the bench and to bring into the game Celeste Vallejo to talk about some of our optimization efforts. You ready, Celeste?
Yes, thanks, Scott. Okay, so I will talk to you about a couple of the studies that we use to optimize OBESITYsym. So the first is a study done in obese patients. Semaglutide was administered over 68 weeks. And within that 68-week period, they did 5 dosing up titration steps. In addition to drug administration, patients were given a lifestyle intervention, and this consisted of caloric intake reduction as well as prescribed physical activity. So within this study, there was a placebo group which just received that lifestyle intervention, and then there was a group that was dosed with the drug, and they got both the drug as well as the lifestyle intervention. Now, if you look at the plots on the right, on the left-hand column, you have the results from the placebo group, and on the right-hand column, you have the results from the group that was dosed with semaglutide. The top row shows you the % weight loss over time. Our simulation results are given in red, and the clinical data is given in black. And as you can see, we have really nice agreement between the model and the clinical results, both in the group that was dosed with the drug, but also with the weight loss that was reported from the placebo group, which can be attributed to that lifestyle intervention. So our model is able to capture both of these different phenomena very nicely. So that is the drug efficacy part, but as far as the potential for adverse events, our model is able to capture them similarly well. If you look at the bottom row, here we're going to see the proportion of subjects reporting nausea over time. And we found it was really interesting in the clinical data, and this is most apparent in the group that was administered the drug. If you look at the plot on the bottom right-hand side, with each dose up titration, we saw an increase in reported nausea until you got to the highest dose that was going to be given. And then with continued dosing, we see a drop-off in reporting of nausea. So patients are now becoming tolerant to the drug. And our model is able to reproduce this as well. So you can see our model results are in red, plotted against the clinical data in black. We can recapitulate that very nicely. Within the placebo group, patients also reported experiencing nausea, and we think this is potentially due to a white coat effect. But our model is able to capture this as well. So kind of both sides of the spectrum, our model is able to reproduce very nicely. So if you go to the next slide, we also had a study that was done with semaglutide again, but this time in type 2 diabetes patients that we were able to use within OBESITYsym. So semaglutide was administered over the course of 30 weeks. We still had 2 dosing up titration steps, but no lifestyle intervention because of the patient population that was being considered. And so you'll notice that there are a couple of differences between a study done in type 2 diabetes patients versus obesity patients. As Scott mentioned, the dosing is going to be a little bit lower in those type 2 diabetes patients, as well as the body weight is going to be lower. And this is important to take into account because this is going to drive the pharmacokinetics of the drug, which in turn are going to drive the drug efficacy, or that % weight loss that we're looking at. So the plot on the right gives you the % weight loss over time. Our model results are in red and the clinical data is in black. And as you can see, we're doing a fairly good job of recapitulating the data. We're maybe over predicting a little bit. We're, 2 different patient populations. Here is again, the type 2 diabetes, and the previous slide are the obese patients. This study did not provide temporal nausea data. However, we were able to match the overall reported nausea incidence. So we simulated about a 20% nausea incidence, and the study reported 17.9%. So overall, we're able to match both the drug efficacy as well as potential for adverse events. And then if you go to the next slide, we were also able to look at a study of liraglutide in obese patients. So in this study, liraglutide was administered over 56 weeks, again, 5 dosing up titration steps, and then this lifestyle intervention. The study had a placebo group as well, and then a group that was administered the drug. So the placebo group had just the lifestyle intervention, whereas the group that was dosed the drug had the drug in combination with the lifestyle intervention. If you look at the plots on the right, the left-hand column shows you the results from the placebo group, and the column on the right shows you the results from the group that was dosed with the liraglutide. The top row gives you the drug efficacy, so the % weight loss over time. And again, our model results are in red and the clinical data is in black. And so you can see we get very good agreement, not only in the weight loss that was reported in the group that was dosed with the drug, but also in the group that had the placebo, so just the lifestyle intervention. We're able to match both very nicely. And then finally, in terms of the adverse events, if you look at the bottom row, we can see the proportion of nausea reported over time. And again, if you look at the plot on the bottom right-hand side, we see an increase in reported nausea with this dose up titration. And then eventually, once we get to the highest dose level and there's continued dosing, we see a tolerance. So the proportion of patients that are reporting nausea is declining. Again, our model can reproduce this behavior. We also see reports of nausea in the placebo group, and we are also able to reproduce that as well. So overall, our model is able to do a nice job of not only reproducing, reports of drug efficacy in terms of the % weight loss, but also in terms of the reports of adverse events, in terms of the incidence of nausea over time. So now I'll turn it over to Zach to finish the rest of the optimization and validation data sets that we used.
All right, thanks, Celeste. So we can go to, awesome, thank you. I'll take a look at a few tirzepatide comparisons. So in these cases, similar to what Celeste has just shown in terms of process, tirzepatide was administered for 72 weeks with an up titration staging, lifestyle intervention as well. In this case, what was already alluded to by Scott, tirzepatide has 2 mechanisms. So we have the GLP-1 agonist, like the preceding 2 treatments, but we also now have a GIP-dependent mechanism. And so that's contributing to both the enhanced weight loss effects compared to the previous 2 treatments, and also the mechanism acts to mitigate nausea effects. And so in this case, we're seeing for the first dose of tirzepatide, dosed on the upper right, a significant amount of weight loss on average, but lower nausea incidence, both in the placebo group and in the treated group in particular, compared with the preceding 2 treatments. So we're capturing that here at the lowest dose in the model, both temporally and in the text you can see in terms of overall incidence And then what's nice in terms of the tirzepatide data is that the publicly available information has up titration in the obese population. And so if we go to the next slide, we'll see tirzepatide at 10 milligrams. And so it's hard to see if we're flipping slides, but we are capturing now the dose-dependent effects. So in terms of the body weight change response on the top and the adverse event nausea response on the bottom, both of those are increased relative to the previous 5 milligram, and we're capturing that dose-dependent response temporally in the figures that you're seeing, but then also the overall incidence. Again, in the text, we're capturing that level. And then if we continue forward, we have an additional dose. And so we, again, capture that overall level of response. And, if you kind of look back, the difference between 5 and 10 is much, in terms of the weight loss response, is much greater than between 10 and 15 milligram tirzepatide. So, we capture a dose-dependent response and some kind of overall kind of leveling out of the response within the model. So overall, this is really nice because we're able to demonstrate through these calibration data sets that we can capture a dose-dependent response in the obese population. And the other thing that I want to mention, this is kind of the conclusion of our calibration portion, is that all of the information that you've seen up to this point, we were calibrating all of these data sets simultaneously. So we were putting into the model the semaglutide, liraglutide, tirzepatide dose response, and that the 0.5 milligram semaglutide together and optimizing it. So we weren't fitting one drug and then fitting another drug. These were all fit simultaneously to get these results that you've just seen. So like I said, this is our model calibration portion, leveraging primarily obese patient data with that one semaglutide. Now this is moving to our validation portion. So part of the reason we included that semaglutide type 2 diabetic population is that given the availability of publicly available data, one of the data sets that was that we could leverage was, again, in that type 2 diabetic population. And so in this case, the kind of middle dose for semaglutide, the 1 milligram, was what we held out during calibration and used for the example validation set. And here, the body weight calibration in the figure, we're doing a pretty decent job. Again, a little bit over predict on the body weight response, but well within the margin of error in terms of the clinical data. And then the nausea incidence, again, in the text, in terms of what the simulated incidence is, around 24%, is aligned with certainly one reported data set, and then a little bit above, but I think still in alignment with the FRIAS data set that's used for the body weight response. So again, that's a nice validation of what we put into the model can predict dose that we didn't explicitly include in calibration. So that's nice on the treatment response side. If we look at body composition changes, so that might be a question, like how can we ensure the model's predicting that as you lose weight, that we're capturing the changes within the body, not just body weight. There are two clinical studies that have been examined. There's a study, Martin in 2011 looked at a 25% caloric restriction over 26 weeks. And then Reinhardt in 2015, a 50% caloric restriction over 6 weeks. And some of the nice results there are breaking down by body weight, fat mass, fat-free mass. You can examine the figures on the right to see that we're generally aligning with the absolute change in each of those. And then the figure on the bottom, there are a number of simulated lines underneath the clinical data there. So in terms of the temporal response of change in body weight, we're aligning nicely with the response over the time frame. So, this is a nice breakdown. We've been looking primarily at the body weight changes. This is a nice breakdown that we can model the body compositional changes as well, and validates that our calibrated population represents what we think is happening clinically. So I think that brings us to the end of our kind of model calibration section. And I think the next question or next slide is a poll question, if I'm not mistaken.
It is. Thank you, Zach. Thank you, Celeste. And now we bring Jasmine back in for our third and final poll question.
Sure. So the last question is, are you interested in learning whether OBESITYsym could help your company's clinical development pipeline? And it's looking pretty good right now. We're at 85% yes. Give it a couple more seconds. All right, and we'll end it there. So the majority did say yes. That's a good sign.
All right, let's see if I can move the window. There we go. Okay, then let's wrap up the presentation with just a bit of information on how you can gain access to OBESITYsym. And then, of course, we'll open up the floor for questions and answers. Looks like there are already some accumulating here in a minute. We'll address them. Okay, so let's see. First, the first way, and they're not separate, they're potentially even together, is to engage us, the Simulations Plus QSP group, in a services sort of engagement. We have a ton of experience doing this. We use an approach that's often similar to what's kind of described here pictorially. We'll stage it, we'll kind of divide up the tasks that allows us to kind of have some interim update meetings, keep everybody apprised of progress. Sometimes course correction is needed because additional data or what have you. And along the way, we're implementing your compound's PK, treatment attributes, utilizing available clinical data and the optimization protocols, and then making the predictions to really identify that optimal sort of dosing paradigm, what outputs, what frequency, what duration of study, as well as, because we have semaglutide, liraglutide, and tirzepatide included in the model, we can use those as comparators. So you can get a sense of the competitive landscape, as well as potentially combinations, depending on the treatment approach. Another important aspect here is, we showed kind of full phase 3 studies in our validation and our optimization. In reality, we can work with timelines, efficacy type studies of much shorter duration as well, and extrapolate those out in order to do those comparisons. So in addition to the services project, of course, we make the software itself, the model itself, licensable and available in that way. We're at this point utilizing exclusively a perpetual license, which allows users not only to, of course, access the existing optimization, existing equations parameters, but to potentially modify those as well. So if you need to introduce a novel target, your own, a new PK approach, whatever it might be, licensees have the ability to do that as well. And again, just to kind of hype up, the Thales QSP modeling platform is really nice, like I said, rapidly able to climb the learning curve to establish the use. The optimization is undeniable, as our results just showed. And it allows us to really kind of, not us, but users to really take advantage of kind of top tier QSP modeling in order to do the OBESITYsym predictions. So there you go. Those are our ways. We encourage you, of course, to reach out to our group one way or another if you're interested in either or both. And it's actually quite common that folks are interested in both. I sometimes call that the learn one, do one, teach one. And so, yeah, don't hesitate if you have interest to reach out. Okay, so with that, we'll wrap up with some question and answer. I'll kind of park on this slide for a moment at least, just to remind everybody the attributes in summary. But Steve, it seems that there are a number of questions, yes?
Absolutely. Let's go through a few of them. One question is, what are the predicted responses when the medications are withdrawn from the sim pops? Any thoughts on that, Scott?
Yeah, actually, I'm going to pass that question over to Zach. And are you there, Zach?
I am. It just took a second to unmute. So we did an examination. So using semaglutide, and so looking at this, I think we had a nice response that's in alignment, qualitatively and almost quantitatively with the clinical data. So we did a 1 year on treatment and lifestyle intervention, a 1 year off treatment, continuing lifestyle intervention in the simulations. And we got a rebound of about 42%. And that's what's shown in the figure. And the clinical data, there's a Wilding 2022 dose cessation study. They got a rebound of about 67%, but that was treatment of 68 weeks, and then a removal of treatment and the lifestyle intervention. And so I think, in general, this is an apples and oranges comparison. Or I guess green apple and red apple, because they're kind of close. But I think in general, we're aligning in terms of the model with an available study. So I think this is an area where we want to continue looking at. But I think if you're looking at removal of treatment, we're doing a good job with what we have in the model so far.
And just to confirm, Zach, this protocol that you simulated was not included in the optimization. This is validation. This is a true prediction, yes?
Right. This is taking, the 2.4 itself was, part of the calibration, but this particular simulation and comparison was not included in calibration.
Yep. All right. Thanks. Okay, I'm going to actually stop sharing now because if we need to go back to the slides, we can. But are there other questions, Steve?
Sure. I have quite a few. So let's see if we can go, how many we can go through. Could you predict the weight loss of a drug that increased energy expenditure as a monotherapy and then in combination with one of the existing drugs on the market?
Celeste, you want to handle that one?
Sure, yes. So we have that built into the model through that Hall model that Scott mentioned. So we can investigate all those pathways, definitely.
Very nice.
Thank you.
Are you able to incorporate other GI side effects that have been reported with GLP-1 based treatments?
I guess it's my turn. I'll handle that one. Absolutely, yes. Again, we were kind of, focused on making this tool, this QSP model, available as expeditiously as possible, which is why we focused exclusively on nausea. But I think we understand mechanistically how to capture some of the other events, and I won't name them because we tend to get uncomfortable when we consider them. But at the same time, we're can you utilize the full depth of the Thales optimization engine in addition to our understanding of the mechanism, pull all that together, and much like we did with nausea, I have full confidence that we could do that for some of the other aspects of the GIAEs as well.
Okay, great. And another question is, for each therapeutic, how do you model the level of GLP-1 and GIPR modulation? Do you use in vitro potency values? And if yes, what cell types, etc.?
I'll field that question as well. So yes, we start with, it's also, I'll add to that question in that we kind of implicitly mentioned it, but I'll be explicit. We utilize a PK model. And in this case, there are PK models, I think, for all three of them, published or publicly available. We embedded each in there. Of course, that combined with the potency, which is often expressed in an AC50. I think the data that we used came from the HEK 293 cells. And so that's kind of a good starting point. Of course, we all know what's measured in vivo doesn't always carry forward into in vivo. And there's also, as we showed, tolerance, attenuation, right, adaptation. So that's our starting place. Having the ability, having access to some of the clinical data allows us to really, kind of do the next layer of optimization, in vitro to in vivo. That said, I think our system is robust enough that if you only have, in vitro measurements and it's, kind of earlier in the pipeline, again, we can make predictions based on that. The more data we have, the more confidence we're going to have in those predictions. But I think we have a fair amount of confidence, even just on that minimal set of data.
Great. Was the nausea outcome only calibrated to the weight loss drugs, or did you use any other drugs with different mechanisms for calibration and testing?
Zach, you want to answer this one?
I think we were looking at trying to think if I'm missing anything, but no, we were looking at the weight loss drugs. I mean, it's all the ones that we described in the webinar today.
Yeah. Plus the white coat effect that Celeste described as well. Yeah, right.
Okay, great. Something shifted. It's clear that OBESITYsym incorporates a QSP model of energy balance, but I'm curious to learn more about GLP-1R and GIPR pathway models, specifically on CNS appetite and nauseogenic centers.
Okay, so we have not built that degree of complexity into OBESITYsym at the present time. It's an area we can certainly go into, but I would say there's some kind of challenges there, not the least of which being, I think that we're still very much in the process of learning that specific biochemistry, that neurochemistry. And so, I think there are going to be some big data gaps there. That's often a great way to use modeling, is to kind of help identify those data gaps to support experimentation. In this case, we're more obviously oriented towards supporting the clinical development and getting those drugs to the market as soon as possible. So I think that's a potential area for us going forward. Clearly not a current example or application or attribute of OBESITYsym.
Another one, can you predict long-term effect from short-term data? What is the level of confidence in predictions?
Celeste, do you want to field that one?
Sure. So like we showed with the semaglutide, the 1 year on, 1 year off, we can predict long term what would happen, especially, in that case where we had taken the drug off. What kind of confidence? Well, I'm not sure. It kind of just depends on how much data you have, right? How far into the future we can predict, but.
And then and let me also reframe it for you, Celeste, in that not just on-off, if you will, cessation of dosing, but what if someone comes to us with, say, 36-week weight loss data? Could we predict, use OBESITYsym to predict out what would happen at 72 weeks?
Sure. Yeah.
And by relying on what we've learned from the existing drugs, the existing optimization, that enables us to have some confidence going forward. Yeah. Yep. Any other questions, Steve?
We're starting to run out. Let's see.
Why don't we make this the final one then?
Okay. Let's see. How about, all right, so here's one that takes it from a different angle. Congrats on your new QSP model OBESITYsym. Just wondering if you have explored various diets in your model. Specifically, I'm interested in how the model responds to diets that use only one fuel source, meals with fats, or no/low carbs, or meals with carbs, and no/low fats.
So I'll remind you of our disclaimer. We're not providing any medical advice for patients. But yes, we have, maybe not that extreme, but we have indeed simulated different dietary backgrounds, distribution of macronutrients, et cetera. And again, I don't think we've done, to be clear, anything quite that extreme. But really, looking at a range of different macronutrient distributions, for sure. That's part of the validation, understanding the model. Yep. Okay, I guess with that, we'll wrap it up. Thanks, everybody. Really appreciate you giving us the opportunity to describe OBESITYsym, its attributes, and look forward to hopefully talking more with you about it in the future. So long, everyone.
Thank you all. For any questions we were unable to answer live today, our business development team will reach out to you with answers following the webinar. You can learn more on our website. You or your colleagues may also be interested in our other upcoming webinars this month. They're also on our website. I put the links in the chat. This webinar has been recorded for playback and will be available on our website and YouTube channel. This concludes our webinar for today. Thank you again.
Thank you, everyone.
Bye-bye.